Welcome to the April 2017 BJS British Journal of Surgery Editor podcast. I'm Robert Hinchliffe. I hope you enjoyed the special issue on surgical infection. The BJS would like to thank all contributors to a fantastic issue. If you haven't yet had the chance, I'd really recommend visiting the BJS website where you'll find the issue free to download. As usual, there's something for all surgeons in the April issue. The leader on translational research by two of the BJS editors, Malin and Kjetil Søreide, on surgical oncology, issues a clarion call for surgeons to get involved in the omic revolution and help bridge the translation gap. The authors make the point that the role and place of surgery in cancer is changing, and surgeons must be in the vanguard of translational research to help correctly position surgery for the future. Now, how do you diagnose an anastomotic leak after colorectal surgery, something which we are all familiar with? Authors in this issue have analysed the role of some 51 biomarkers, either singly or in combination. And as many of you might have guessed, the authors conclude that clinical judgment remains very important. It seems that the functional mucus layer plays a key role in the integrity of these anastomoses and development of leaks. And there is a paper on just this topic later in the issue. Emergency surgery is a key component of most surgeons' workloads, probably about half of it. Unfortunately, a systematic review has revealed that the evidence to underpin much of this activity seems quite poor. Gallstone disease and appendicitis have been quite well served by randomised trials, but there are fewer in bowel conditions and even fewer in conditions comparing surgery with a non-operative approach. There are two important randomised trials in this issue. Firstly, the Orange 2 trial comparing open and laparoscopic left lateral hepatic sectionectomy. I do wonder whether these sorts of trials of open and laparoscopic surgery still have a place, or whether surgeons should be advised to undertake the surgery that they have been trained to do and audit their patient-related outcomes appropriately. Anyway, as you will see from this randomised trial, there are some very important lessons to be learned in regard to how most surgeons should set these trials up. Post-operative pancreatic fistula are common and serious complications. There are many methods that have been developed to prevent them, but in this issue, authors randomise patients to either pancreaticogastrostomy or a hand-sewn closure after distal pancreatectomy. To find out which offers the best approach, you will have to read the paper. We all recognise randomised trials to offer the highest level of evidence, but we are all acutely aware of the Hawthorne effect, of the results not matching the outcomes in everyday clinical practice. An important paper from Sweden in this issue compared the outcomes from a randomised trial of laparoscopic gastric bypass versus the outcomes from the same procedure in a national database. The results, I can tell you, are really quite reassuring. But what about nationwide access to complex surgery and their outcomes? There have been many examples of quite severe variations of care, even within the same country. In Norway, it seems that there remains a postcode lottery for resection rates and survival in those with colorectal liver metastases. Not only is there a variation in the type of patients, but also in the surgical approach and outcomes. One explanation may be that Norwegian doctors managing patients do not follow national and international guidance. In contrast, UK breast surgeons appear to offer immediate reconstruction to patients with breast cancer, but they're still swayed by patients' age, and perhaps unreasonably so. There are also papers in this issue on the utility of radiofrequency ablation in addition to surgical hepatectomy for liver metastases, and a novel angiographic scoring system for patients with peripheral artery disease, which may prove useful both as a classification and prognostication tool. Well, that's it from me for the April issue. All it remains for me to do is to draw your attention to BJS Open. This is a new open access journal from the BJS stable, sharing all the high quality aspects of BJS in general surgery and related topics. It's a different type of open access journal. You will not be allowed to submit directly. Instead, If you submit to BJS, you may be given the opportunity to publish your paper in BJS Open. Only high-quality articles will be given the opportunity to transfer in this way, so you can rest assured that BJS Open will maintain the same BJS high standards in surgical publishing. Thank you for listening, and I hope you enjoy reading and discussing the issue.